Our next speaker, I found out about at a conference last year in Leeds called Inspired Medics, which was a very inspiring event. And unfortunately, I missed her talk, but I got talking to her, watched everything that she's done on YouTube, and it's incredible. And mental health is something that we all want to address and improve. And our next speaker is very, very good at addressing these issues. So without further ado, I'd like to introduce consultant psychiatrist at the Hertfordshire NHS Trust, Dr Pratima Singh.
Thank you very much, Sam, for giving me an opportunity to talk about something that I'm really passionate about. Just to have a sense of the audience, can I just check how many GPs we have here? Okay. Thank you. And how many patients or patient relatives, carers in the audience? Excellent, thank you. So I realized many of the questions after these presentations were always curiosity about how I got here. So now I cut the chase and I begin with that. So my story obviously begins from where I come from. So I come from India, and I come from a place where many medical practices coexist together, just like many different cuisines, religions, etc. But there's also a very typical preference for home remedies or remedies that come from cultural norm, which would be your go-to rather than the medication cabinet. So there is an inherent curiosity about how we can use food to correct things, as well as how food can cause problems with the health. So when I went to medical school and after I graduated, I did not bat an eyelid. In fact, it was a part of my history taking that a patient would describe to me many different forms of alternative treatments that they would have tried and sometimes are trying alongside modern medicine. It was not scorned off, it was not dismissed. How much curiosity or acceptance there was definitely differed amongst practitioners. My own mother suffered from rheumatoid arthritis, has a family history, and managed to remain very, very well for over 3 decades without any deformities using alternates. So I had an open-minded acceptance and reverence for things other than modern medicine. The other curious phenomena that I observed that happens, which any doctor who's trained in India would tell you, that at the end of almost every consultation, whether it's for a headache, for depression, for cardiac issues, for a foot pain, for a broken toe, the patient would ask, "Doctor, what should I eat?" And I mean, when this was asked of me before, as one does when you're newly qualified, you try to give an intelligent answer, but you have no idea what you're talking about. But I think the question really comes from the legacy of Ayurveda, where there is a recognition that most diseases begin in the gut. And there is a centrality of gut health almost at the core of treating any long-term condition. So it would not be unknown in Ayurveda to begin a consultation by taking a history of the patient's diet, but also about their daily bowel motions. In fact, bowel motions, observing your tongue as well as the other end of the alimentary canal, is a practice, a very standard part of history taking in Ayurveda. But I'd be lying if I said it's all because of the wonderful culture that I come from. Fortunately, I don't come from a very normal family. Yeah? And when I say that, what I mean is in terms of the cardiovascular morbidity, I've never seen anything like exist in my family. So both sides of my family, including my parents, both sets of grandparents, and every other cousin has a diagnosis of a cardiovascular illness. My cousins in their late 20s are diagnosed with either diabetes or high blood pressure. I'm the only person in my family who in their 40s yet does not have anything. But who also did not have any long-term condition was my father. And my father is an agricultural scientist, and tabletop conversations at dinner included rants at Monsanto, telling me how genetically modified crops were going to destroy health. And being an agricultural scientist working in the area of cotton genetics, my father was very open about the huge corruption that he saw in the influence of big food about introducing GMO crops in India, and now it has happened. So, when we talk about why, after coming abroad, you can't tolerate wheat, but you go back home and you can enjoy a chapati without a problem, it might be because we are not talking about the same grain. My family is also unusual because this is a common morning sight in my family. That's actually my family. The very handsome man in the bright yellow Bermuda is my 72-year-old father. And this picture is taken 24 hours after I landed in Nagpur, where I come from, with their year-old grandchild who's in the high chair there. So this happens in my house. Two of those people are my neighbors, and two of them are parents. So I definitely come from a family where my father practiced lifestyle interventions. We had home-cooked meals, and we tried to do best in what we could. So this really comes from fundamental way that I lived life. And then I come to UK. I can tell you in 15 years of being a psychiatrist in the UK, both in training and practicing, no patient has ever asked me what to eat for their mental health. And I'm working towards changing that. But I think life came a full circle in a very painful way, in kind of observing that my patients, just by virtue of having a diagnosis of a major mental illness, such as schizophrenia or bipolar, would die 15 to 20 years earlier than their counterparts who did not have this. And that was disturbing. It was really disturbing because this coincided with the time that I came to UK in order to learn to practice a better way to do mental health, which I assumed did not exist in the culture that I left behind. What it showed that men had a higher risk, but if you had bipolar, the risk was around, life expectancy was around 13 years shorter, and for schizophrenia, it could be up to 20 years, 18 years being the average. What was the other disturbing fact is that in the time that I have been in the UK, this gap is not shortening. We are using several times more of medication, but the gap is slowly widening, and I think it is really disturbing that in a developed country, we don't know how to improve life expectancy in patients with longer-term conditions. There is very, very significant data to show that a large part of this morbidity is probably due to treatment, mainly the second-generation antipsychotic treatment, but it is not as simple as that. There is also data that shows otherwise, and this is a very important Finnish cohort study that had over 60,000 patients who were followed over a decade, and the data shows that there is excess of mortality in patients who are treated with some atypical antipsychotics, but not another kind, which is mostly associated with the highest amount of weight. So there is some correlation between people being well from an illness is protective, but the treatment definitely adds to the cardiovascular morbidity. But today I'm here to talk to you because I'm not a researcher. I am a clinician at the coalface, seeing patient after patient that come to us. So what I observe that we do about this increased mortality, increased morbidity from cardiovascular illness is actually very superficial and tokenistic in my opinion. So there are a few psychiatrists in the audience who I think will agree that we are inundated by repeated monitoring. And so we have lots of systems, lots of incentives, lots of registers my GP colleagues have to follow, and lots of financial incentives in the system to record the cardiovascular parameters. But if you chase these further, what you would realize that nothing happens in between monitoring until when patients actually develop the condition, let's say diabetes. So it's almost like we are waiting, we are counting down the time to actually when people develop diabetes, and then we treat it. Yeah? So there's almost a nihilistic kind of a helplessness that the profession has adopted, that this cannot be intervened with. or maybe the fantasy that it is somebody else's problem. So if I pick up raised blood sugar or a raised cholesterol, HB1AC that's problematic, all I'm required to do as a specialist is send that patient to the GP to sort it out. And I think we are letting patients down by that mentality. I think why this sits uncomfortably is when I look at the state of the other interventions we provide, many of the patients do not respond to medication. There is a disturbing rate of compliance as well as discontinuation symptoms. So patients might remain on medication without any benefit, but the same medications can be very difficult to come off. CBT is now offered for almost everything under the sun, and there's declining evidence that it actually works that well, which is the most commonly offered psychological intervention in mental health. Psychotherapy, which might, different kinds of psychotherapy, which might be more relevant to the chronic mental health problems that we see that are associated with childhood adversity or trauma and can have lifelong consequences, which we know affects both physical and mental health. Sometimes the thresholds can be too high because of declining resources, or the patients who are using substances or other, dysfunctional ways of managing those symptoms might be the very ones who are excluded from those treatments. There is definitely a rise of social interventions, which I think is one positive. But overall, I wonder if the overall effect of seeing these patients again and again without feeling that people are getting better contributes greatly to burnout, both for the GPs but also for the specialist. I've come across, I'm only in the first 5 years of being a consultant psychiatrist, and I worry when I see some of my seniors feel like they are helpless in making any change. In thinking about burnout and how it affects me, because I can tell you as a jobbing psychiatrist, it feels impossible. The task feels impossible to manage the level of mental health morbidity, but also being a witness to the worsening physical health of our patients on a day-to-day basis. I came across the concept of moral injury in a podcast by Dr. Rangan Chatterjee, and it really resonated by me because I realized what I was feeling was slightly something more than a burnout, and what my colleagues were talking about was more than burnout. It was the fear that you were actually doing harm through your interventions, and I would go on to say due to denial. So iatrogenic harm, now when I prescribe medication to somebody who insists or who feel they're not able to commit to other changes, it makes me wonder, I know they are not going to get better on it, so am I introducing harm because I cannot do anything? I also think we as a profession will stand witness in 50 years' time to answer to a community who will ask us, why did we not intervene when we knew this was giving rise to such levels of cardiovascular mortality? So when I prescribe something like olanzapine, patients increase in size in front of my eyes. And I think a part of the informed consent should be telling patients that by virtue of being prescribed this is what's going to happen to you. So when I prescribe olanzapine, I'm almost prescribing diabetes. So what is it not my ethical responsibility then to introduce them to a program that will help them mitigate that risk if they were to remain on that treatment, or to introduce them to a program like we have been talking about for the last 2 days, which will help them possibly be on the lowest dose of medication or without medication to manage their condition. So the mind-body split is therefore quite alive for me in every patient that I see. And my job, I would say, is made slightly easier because doctors are in the habit of asking for evidence. And when there is good quality evidence that comes up, it makes it easier to make the recommendations. So the evidence is very small. There are a handful of trials, most of them in the last few years, although I will mention data about different kind of studies that have been out there for decades that are not very well known. So the SMILES trial is one of the first randomized control trials, which has used adjunctive dietary intervention for patients with moderate to severe depression, and it uses coaching in terms of 7 nutritional consultations with a registered dietitian. The control arm consists of social groups, so everybody is getting some human contact. The content definitely differs. And over 12 weeks, there has been shown to be a significant reduction in the depression scores in patients who received the dietary intervention versus the social group. Small numbers, but impressive outcomes. The health limit took it a bit further because, as you have heard, nutrition research is not easy to do. Yeah? It is much even harder when you are depressed and might have very low motivation to shopping, cooking, sticking to a Mediterranean type of diet. In the HealthyMed study, patients were with, again, moderate to severe depression were actually given a fortnight worth of hamper of food along the Mediterranean lines and fish oil supplements. So the fish oil supplementation was a pragmatic replacement for actual fatty fish because of portability and dosing. So the current existing trials that support omega-3 supplementation as an adjunctive treatment have a very specific recommendation about what the dose should be. So I think this just makes it easy to control. The other unique thing about the HealthyMed was that patients also received cooking instructions, which I think from a clinical point of view, it completely makes sense to me, and I'll come to that later. And again, outcomes show that a significant improvement in depressive symptoms in patients who were in the dietary arm of the study. So this is more like a review of what are the common themes arising, and I think it will be no surprise to anybody in this audience that the 5 key dietary recommendations that have come out is that a Mediterranean type of dietary pattern, which is also called as the traditional dietary pattern, yeah, so it could be Norwegian, Japanese, not necessarily Mediterranean, is protective in prevention of depression, and this is characterized by an increased consumption of vegetables, legumes, whole grain cereals, nuts and seeds, and also includes a high consumption of foods rich in omega-3 fats, and you're mainly replacing unhealthy fats with better alternatives and limiting and cutting down processed food and sugar. The conclusion is that eating this way reduces your risk of developing depression and therefore has a preventive role. If we look at things from the other end, literally, composition, when you study the composition of the gut microbiota and compare it with different type of diets, there have been lots of discussions about different diets, and it's an area that I do not go into with my patients because there is so much else to go into. But this is quite reassuring that whether you are a habitual omnivore, vegan or vegetarian, it is the common factor would be the Mediterranean component of all those diets that will give you the benefit in terms of your microbial diversity. And I think the emerging evidence was neatly capped by this excellent systemic review that came out last year from Camille Lassalle from University College London, which not only showed what again would probably not be surprising for this group in looking closely at 20 longitudinal and 21 cross-sectional studies, was that it had a preventative role, and the preventative role could be as much as 31%. It's unmatched with anything else that we do in mental health. So, other than these trials, I think generally the interest in gut microbiota has given a platform for people like me who kind of thought it was obvious before, give a legitimate platform to begin this conversation with our patients. So this is a slide from Nature by Ted Dinan's group, who have done a lot of work in this area. And I think it's important to use this data to make a case and clarify that what we know currently is actually very early stage. Yeah? Lots of my patients already come and ask about recommendation for probiotic. And what I do is I explain to them that our understanding is still in very early stages, and they would have much buck for their money investing in eating differently rather than buying probiotics. But how does this work? How does the gut-brain microbiota connection work? How does it talk to each other? There are three main mechanisms of actions that have been hypothesized. One of it is quite straightforward, is through serotonin. So 90% of the body's serotonin is actually made in the gut, which is the enteric nervous system rather than the brain. It always is a conversation starter with patients who, because the patient would tell you that's their experience when they use SSRI medication. They have gut symptoms before they notice any other change. The second mechanism is through the influence of the immune system in the gut, which then has a change in the neurophysiology of the brain. Again, something that we are in the very early stages of trying to understand. And the third, which I think is quite exciting and I think is probably a bit easier to study in animal models, is what are the bacteria actually producing that might be the signaling molecules that go up to the brain? Because we definitely know that the neurotransmitters on the left produced by the bacteria do not directly travel, which is a very common misconception in patients when they come, that they think that the probiotics they are taking are going to the brain or the metabolites. It doesn't work. It's not as simple as that. So we now know is that gut is not just yet another organ like your lung or your kidney, but it's a dynamic organ. It's a dynamic organ mainly because it is changing, it's reviving on a continuous basis, mainly through what you're putting into your mouth. And I make a lot of song and dance about this when I'm talking about this to my patients, that every morning, afternoon, and evening, and in between if you're snacking, what you're eating is influencing your gut microbiota much more than how you will influence it by taking that one probiotic in the morning that you probably cannot afford. But what also we clarify is that it is not all the bacteria. Yeah, it is not just the matter of transporting loads of good bacteria into a bad intestine. Yeah? So homing or providing the adequate environment for the bacteria is as important. And we educate about the use of prebiotic fibers. And this is where I meant that the third mechanism of action that we're trying to understand is the role of short-chain fatty acids. Interesting molecules, both a substrate for the good bacteria in the gut, but also produced by them, that play a role in signaling the brain. The probiotic are then the live bacteria. Again, very varied research. If you look at research of using probiotic in mental health, the outcomes have been both ways. Yeah? Negative trials, some positive trials in humans. There is no current evidence of any particular strain of probiotic causing any significant improvement in depression symptoms. But the third component that I think we need to start thinking about to remove the obsession about probiotics per se is postbiotic. So what happens when you have a good prebiotic supply, you have a good environment for the good bacteria to thrive, what comes out of the bacteria, the postbiotic, are probably the most important things. So if you have an abundance of pathogenic bacteria, the things made would be pro-inflammatory, like the lipoprotein, the polysaccharides. Whereas if you have a good production, you have a good colonization by healthy bacteria, you'd be making more of the short-chain fatty acids, which then will provide food for the remaining bacteria, but also act as signaling molecules to the brain. We also know from animal studies that if you take sterile or germ-free mice, which are the common models to study the microbiome, that transplantation, so fecal transplantation from depressed patients into germ-free mice makes them act as if they are depressed, versus controls when the microbiota. So at least in rat models, it seems like only changing the microbial composition appears to have an effect on their behavior. Again, very difficult to replicate this in humans, although fecal transplantation does occur in some areas of medicine. I think we are far way off to ever see this kind of study in humans. in rat models, there are also some specific strains. So, for example, a well-known anxiolytic strain in mice is Bifidobacterium longum, and it is becoming clear that one way in which the enteric microbiome and its effect communicate with the brain could be through the vagal nerve. So, after establishment of the anxiolytic effect of this particular strain of probiotic, it was found that if you vagotomized, if you cut the vagal nerve of the mice, the anxiolytic effects were stopped. So, there is some communication. So, it's like information superhighway, the vagal nerve that, does the job. But again, I think that is the limit to what we know at the moment. Every time people, because I think microbiome is the apple of the research and the media's eye at the moment. It's going to solve everything in the world. But I think it's quite humbling to note that none of this is new. Yeah? So this is a study from 1910, actually from somewhere, a place where I trained, where psychiatrists were making kefir on sites of Bethlehem Royal Hospital to treat depression. I think I also came across the other day work of Russian microbiologist who studied the gut microbiome. So he was a Nobel laureate. I think his name is Elie Metchinov, who believed that aging and the effects of aging were related to the colonization or the putrefaction of bacteria in the gut, and how that research, although very popular at the time, was overshadowed by the discovery of penicillin. So none of these ideas are new. How they progress or what they are taken over is something to learn from history. I mean, again, what it means in humans, we don't have any human trials that support the use of probiotics. However, I find this study very interesting. This is, again, a small study where children age, I think 5, in the first 6 months of their life were given a probiotic versus no probiotic, and they were followed up for 13 years, and the outcome that they were looking for was a diagnosis of either ADHD or autistic spectrum disorder during that period of time. 17% of patients in the control arm, but none in the probiotic arm. The 17% is higher even than the population. So again, I think it's an interesting piece of study, but does not yet prove or disprove anything. So, bringing this all together, I think it is easier for me to take the position that I am, looking at the current state of interventions that we currently follow. And I think this paper from Lancet, an opinion piece, really helped in kind of bringing together the current state of evidence, recognizing its limitation, but also maybe shining a light on the evidence that has been there, that has been largely ignored. This opinion paper makes a case that given the state of interventions that we have, the huge level of cardiovascular mortality present in our patients and undiagnosed deficiencies, I think it is important that we consider nutrition as one of the mainstream interventions for use in psychiatry. I think, I mentioned earlier, so one of the things that have been looked at is supplementation. I've started to add this in my presentation because there's always a question in the audience about, what about supplementation? Often get that asked that by patients as well as GPs. The problem with supplementation is working in the limitation of the recommended daily allowance. So you'll see from that arrow at the bottom that currently what we use to look for nutritional deficiencies is something called as an RDA. However, the gap between RDA and the upper limit of normal or upper limit of toxicity, everything in between is optimal health, which might be influenced by the current state of your health, the amount of stress that you are under, whether you are pregnant or not, whether you have another long-term conditions. So our patients are all somewhere in between. So to find an optimum level of dosing for each person might be very unique. So this is Julia Ruckledge's work, who compared over-the-counter supplements with those used in research settings. And her observation is after looking at, I think, mostly Australian supplements, supplements used in New Zealand, were that while they were not very different in their constituents, other than the dosing of vitamin D and A, I think what was different was the dosing. So the supplements that are used in research are much higher in dosing, as much as 12 tablets a day, because they are in chelated form, they are quite bulky, and they cannot be reduced to lesser number of tablets. So you're using over-the-counter supplements or a direct replacement will not produce results that some of these, relatively small studies have found. So, a few of the existing evidence again from Julia Ruckledge, small numbers, but, very respectable double-blind controlled trials show that, so this study is from, for ADHD, and, patients received these strong micronutrients, which have both multiminerals and multivitamins, and they show an improvement in ADHD scores. And the patients who improved were mostly were those who had higher depression scores at baseline. Yeah? And when they look at the deficiencies, other than the deficiency in vitamin D, the patients did not have deficiencies at baseline. So, one of the critique of using supplementation is, maybe they are already correcting a deficiency. So, this study actually tested for micronutrient level, keeping in mind still within the RDA limitation. So, it was not just correcting. How it is doing, what it is doing, we don't know, because the number of micronutrients and multivitamins in the formula. Another study, in something much more severe, which again is quite interesting for me as a clinician who prescribes antipsychotics on a daily basis to some of our most unwell patients. Again, small studies with patients with psychosis who were all on treatment, or treatment of one kind or the other. So I think 19 patients on therapy alone, I think 21 patients on therapy and medication, and 25 patients on who were on neither. And again, same multinutrients. So there are just one or two brands of these mega-dosing multinutrients that are used in research and are actually freely available even in UK now. Patients were then followed up till 2 years. So the interesting part of the study was this was planned as a randomized controlled trial, although the patient refused to be randomized. So it ended up being an open label study. But outcomes show that at 15 months, patients in the micronutrient arm had a much lower use of antipsychotics. So the control arm, the antipsychotic kept on increasing, which would be very familiar to my GP and psychiatry colleagues here. But the main improvements were seen actually after 15 months. So it takes time in the more severe disorders. And after 15 months, there was a significant reduction. Significant clinical reduction in the psychotic symptoms, as well as reduction in the amount of antipsychotic medication doses after 15 months to 24 years. Similar study in bipolar affective disorder. Again, keep in mind that although these are good designs, these are really small studies. So this study is from Bonnie Kaplan in Canada, 300 plus patients with bipolar who were prescribed the mega-dose multinutrient, and show that at 6 months there were not only symptoms improvement, but the improvements were sustained. Again, and keeping in mind that trials for medication sometimes stop at 3 months. So this is not insignificant. This is definitely worth keeping an open mind. This particular study used medication in conjunction with their treatment. So there was no patient who was not on any treatment. So In terms of single nutrients, research only supports, probably vitamin D comes out as the only clear supporter. So other than vitamin D, there is no other single nutrient study that has consistently been shown in repeated trials to be significant. So vitamin D does stand out. So this is a very useful meta-analysis that seems to have taken into account all the major studies, and that shows that vitamin D supplementation as an adjuvant to medication showed significant improvement in treatment of depression. So smaller, smaller effect is also seen. So again, this covers vitamin D, but a smaller effect also for folate, SAM-E, and some for omega-3. Now, although there is no supporting evidence, B12 is a pet of mine. I've been accused of being obsessed by B12, and I'd like to not miss this opportunity because there are GPs in the audience to just mention it. And I think I just want to explain where the bias comes from. I come from a country where half the country is vegetarian. We were taught in medical schools to be hyper vigilant about signs of deficiencies. I think one of my observations after coming to the UK is that because we are not looking, we are not finding it. Plus, there are many other factors. Yeah? The malnutrition that comes from excess calorie looks very different to the malnutrition that comes from a calorie deficit or nutrient-poor diet that I used to see in India. The other useful reminder is that what we test does not tell the whole story. So the serum B12 that we routinely test in the NHS basically tells you that whatever number you are seeing, 80% of that is in an inactive form. So if you have a patient who is at the lower level of the normal for B12, then and is presenting with symptoms, not just anxiety or depression, but systemic symptoms that could be related to B12, I think it is worth a trial of correction because it could be the cheapest, easily fixable thing that you can do for the patient. My other concern is seeing patient after patient who is diagnosed with pernicious anemia, whose B12 is tested once they are on intramuscular replacement therapy. I mean, the level is going to be normal. In fact, the level is irrelevant when they are on intramuscular, and then their treatment is stopped. I can tell you, at least in the last month, I have seen 2 such patients who had a diagnosis of pernicious anemia 10 years ago, and their medication, their treatment is stopped. And then there follows a 10-year history of chronic psychiatric morbidity, multiple referrals to neurologists, medication list that Dr. Lake showed us before, where there could be things like pregabalin, and I often joke with my GP colleagues that 1 week of pregabalin will pay for a year's worth of B12 injections, so it is worth testing that. But this is another reminder that when you have the malnourishment coming out of eating poorly, then you will not see the typical megalocytic anemia that you and I are trained to look out for. And just a reminder that iron deficiency coming out of poor diet will confound the macrocytosis of B12 or folate deficiency. Folic acid supplementation. Folic acid is a component of almost all supplements that your patients are probably taking without your knowledge, will also stop it from having a clear-cut megaloblastic picture. The third thing to keep in mind is that if patients have megalocytes in their blood, in the peripheral smear, it's probably a very advanced stage of deficiency. By that time, you are seeing patients for everything underneath, which can be very difficult to treat. So if there is any GP, if you're confused about why a patient is not working, well, it is worth checking for the homocysteine, methylmalonic acid, as well as active B12, which neither I nor a GP can test. It can only be done by a hematologist. Again, I think a very expensive next step for something that can be treated. I think from the patient's point of view, it leads to a delay in treatment and sometimes irreversible neurological damage and treatment-resistant anxiety that just does not respond to anything. So this is very familiar to me from a clinical point of view. So, I think every GP needs to be aware of that there are thousands of patients in UK who are self-injecting because of the lack of support or the knowledge that they feel the medical profession is not keeping up to date with. There are some very good patient groups, slightly provocative, but I think sometimes provocation is needed for us to look into our practice. Sorry, this slide, I just want to mention that another complication of what we do is because folic acid can be easily replaced by oral supplementation, and is very commonly done by doctors, it can actually mask B12 deficiency or make it worse. And I just find this paper very useful for the mechanism. What I also joke about with when I teach GPs, just to be a bit that if you were a dog in UK, you could have weekly B12. If you are a human being with pernicious anemia in UK, NICE allows you to have 1 injection every 3 months. And we talked a lot about, the evidence is as good as where the evidence comes from. At least I have not found any evidence to support it. You dig and dig, and many of these patient forums dig. And this particular slide is from the b12deficiency.info org, and they have done this themselves. And if anybody finds it, I'd be very curious to look at what evidence was used to advise this once in 3 months. At least for my mental health patients, maybe it works for patients who do not have neuropsychiatric symptoms, but for my mental health patients, once in 3 month replacement doesn't seem to be enough. So, just kind of bringing it all together about evidence-based medicine. So if you think about, practicing in an evidence-based way as a psychiatrist in an inner city area, what do? I mean, do you really have the strength of the evidence to promote a medication first, everything else mentality? Or, from what is emerging, could we say that the level of cardiovascular mortality, what we know is going to happen as a result of the treatment, means that dietary and lifestyle interventions need to be a part of every consultation? I definitely believe so. So what do I do actually when I'm in clinic? The first thing I have ring-fenced is the amount of time that I see patients. For both organizations that I've worked as a consultant, I've insisted that I will see every patient for an hour, of which the last 5 to 10 minutes is saved for a lifestyle consultation. I ask every patient about a typical day, and I take at least 1 day food history, which I repeat whenever I review them. It would usually include a rough idea about their waking and sleeping time and everything they eat or drink in between. It really helps having a baseline to decide where do you travel next. I also ask about activity, what are they already doing or they have stopped doing since they became unwell. I watch out for a balance of mastery and pleasure, because I find that in a group of patients who have very little in life, who might have lived a life struggling with their mental illness, food can become a place of obsession. I've definitely worked with some orthotics where I have learned that, without getting a good balance of things in their life, without adequate psychological support, food could become an unhealthy focus, which can be tweaked and tweaked and tweaked with the exclusion of everything else. So I think it is good to get an idea of that beforehand. What to expect? Surprise, surprise, mental health patients eat really poorly. But I think what never ceases to surprise me is how spectacularly badly people can eat, even when they're struggling so much. So, before kind of venturing into this area, I used to say to my friends that I feel like I've heard everything. You just hear the most unbelievable traumatic history from patients. I think this is my turn. I get traumatized from what I hear about how patients eat. So I've heard patients living on 16 cups of coffee. I have worked with patients in their early 20s who tell me that they have never tasted water since they were X years of old. Water tastes bitter, so they have only drunk fizzy drinks. So you don't assume what people are telling you. Actually ask for it recorded. what you ate last, a day before usually works for me, but I'm sure there are more accurate ways of measuring it. I'm also struck by how long people can go without eating and then compensate by binging. Again, probably not a surprise that for many mental health patients who are not eating well are fueling themselves with sugar, caffeine, and nicotine, and there, you've over time you learn to look out for certain signs, such as nocturnal panic is a common one when you have fluctuating blood sugar. I also learned that food is not food when it comes to mental health. It's loaded with personal meaning. It's a reward. It's a vice. It's their thing. It's non-negotiable. It is that area where you're not allowed to come, or an area that they will freely talk about, smile, and connect with, while it might be quite difficult to talk about other things. It is also something, it's a skill, it's an area of skill development. Yeah? You either have the skill or you do not have the skill, or you're not confident about the skill. So food is just not about eating. It's not about reading the label. People require a lot of confidence, and some people, patients just do not have confidence to do food, as one of my patients says. So, some of this I put in this slide, although this is actually work in progress. So we were trying to validate the standard dietary questionnaire, the same one used in the 2 RCTs I've mentioned, to see if we could replicate that in UK, because that studies from Australia, and there were things like kangaroo meat on it, which we don't have here. So it was being validated for UK, and what we did as a part of that was to get 14-day food history over a month-long period, where people were both patients, depressed patients, were recruited to record what they are eating, drinking, both in terms of a food diary, but actually taking pictures. Now, this was being done by my master's students, and when she started to analyze the data, so this is ongoing, this is not published, I don't know the current set, but we looked at the data, and what came out was that it's not only the depressed patients, but even the normal controls overestimate how much fruit and veg they eat, and underreport, both groups underreport snacks. So, when you are in a consultation with a patient, important to keep in mind that it's not a phenomena of being depressed, but human beings in general, when they start to look at diet, might have a rosy view of how well they are eating or how much they are eating. So the tools that I use in consultation, because I have 5 minutes, sometimes less, I use them repeatedly. I'm a big, big believer in repeatedly reinforcing interventions, and not, I think we have probably reached the stage that we have because we have all thought somebody else can do it better. It can happen with one dietary consultation. That's not my experience. Many of my patients have seen dietitian. I often ask them, could you tell me one thing you remember from them? And they don't. Yeah? But I think if they're seeing their GP, they're seeing the psychiatrist, they're seeing their community nurse, the person who gives them their depot, if we are all kind of talking about it, I think there's a cumulative power of these incremental messages from somebody they trust. I've also learned that patients really like seeing things. They ask me to email it. Sometimes, they will send me things back. I have also learned that some concepts are very difficult to change. The idea of breakfast, even from my colleagues, when I present, they ask me what's wrong with cereal. So cereal is breakfast is cereal. There is also very set notions set by the culture that you've grown up in. So I was just thrown when I came. I said, how is that a meal deal? That's not even a meal, leave alone a deal. How does a sandwich, a fizzy drink, and chocolate bar make a deal? I think people have tried to explain to me that the chocolate is the pudding, and I don't get it. So, if you're moving from a meal deal to a meal, you can see that if a person's idea is that, then showing them the Mediterranean diet is just too big a step to move from. So you have to make swaps from where they are at the moment. So this is my laminated sheet, number 1. What I do with this when I'm talking to patients, when I've taken a one-day food history, is that I put my finger and start tracing down, and I start telling them, so okay, you woke up, this is where you have your sugar with 2 coffees, this is what's happening, and then you have your muffin with the honey on it, and this is what starts to happen. This is when your cortisol starts to release a stress hormone, because the sugar is crashing down, and I use this in every consultation and tell them what would happen with the swap. What happens if, porridge and banana for my patients would be a step one, so don't throw eggs at me. So I tell them that, maybe this will probably go a bit lower if you had a slower releasing carb. Maybe if you replace it with egg and avocado, this is what happens, so on and so forth. This slide is not mine. I have no idea whose is it. I mix so many things on the internet, I lose track. So that's why there's no reference to it. This other slide is definitely from permission, and I realize people smarter than me also nick stuff things from internet. So this is Bonnie Kaplan's slide, and when I asked her for permission to use it, she said, Pratima, use away, because 15 years ago I took this from internet. I don't know who made it. So thanks to whoever made it. But I love this slide, and this and the dopamine synthesis slide is really powerful, because this is what I pull out when patients say my medication has stopped acting. And I said the medication will probably not fix something that is deficient in the neurophysiology. Yet the role of nutrients in the multiple pathways that support serotonin production have to be supplemented by a decent diet. And again, incrementally showing this again and again makes it easier for me, because then I don't feel like I am pushed to provide that perfect pill that will act better than the 10 different that they have tried before. Lots of my patients struggle with motivation, and again, I use the same method to kind of coach them into why looking at their diet might unblock. I mean, again, this is not hardcore science, but I think from a neurophysiological point of view, I don't see how this does not make sense. That if you are severely anemic, what could be the roadblocks, and having that conversation, could we work on that? Treating your anemia might give you a bit more energy, and if you have a bit more energy, you will do more, so on and so forth. Slide number 4 is what a Mediterranean diet looks like. So again, as you can see, this is a picture of a picture I have taken, because even on internet, I've not found something suitable enough to steal. So this is roughly kind of showing patients how to load their plate, but also how to do it from the point where they are. So I'm a big supporter of whatever works for you to be in a better place from where you are now. You develop a lot of humility when you start to work in this area, and especially I've learned a lot. So I often begin from what is it that you want to change? As you can guess, for the younger patients, it could be something like acne. I'm just surprised how many of the ADHD treatment clinic male patients worry about their acne. So that's where I start. For the middle-aged group, for men, it could be some sexual dysfunction. For women, it could be weight or the PCOS. So you use whatever is meaningful to them. I've yet to find anybody under the age of 50 who is least interested in knowing what are the cardiovascular events that might happen when they are 65. It is just a very difficult concept for them to get your head around. I dissuade eating. People ask me about diets every day. I think every 3 months I learn about a new diet that I had not heard about before, that I go and Google. I've used this acronym. So the first stage I would do is I would ask for 1 month for patients to commit to stop eating CRAP. I've been attributed to this acronym just to say it is not mine. I've nicked it from somewhere. I don't remember where it's from. But I think it's an easy one. Patients remember it. Cutting out carbonated drinks is a biggie for my patients. Cutting down refined sugar, which means added sugar, before cutting down. So cutting down the cakes, cookies, probably are stage 2. Artificial sweetness, I talked them about the emerging evidence about the negative effect on the microbiome, as well as their blood sugar and processed food. I advise to them what works for me. I am definitely somebody who will eat junk if it is available, even with all the knowledge that I have. And what works for me is not to buy it. So, encouraging them, making it easier, not letting them have a battle of willpower with every decision right from the moment they wake up, because they have very little when they are depressed. First talk, then clear. I've had a few zealous patients who clear out their pantry because Rangan did it in his, and it doesn't work. I think there is a significant amount of planning and education and steps that have to occur. Otherwise, people feel very lost and then they stop and give up. Batch cooking. rotate weekly grocery list. So one of the things that we have to do, people bring Aldi grocery list for me, and we cross out things that can go and add things on it. But also just kind of saying that, not to make it too complex, don't buy the fruits that you bought last week, buy something else. Don't buy the vegetables. See if you have at least 3 different colors in the vegetables that you are buying, and keeping it simple like that. Preparing patients to feel lost. I think I underestimated how few skills patients have when it comes to cooking, preparing, putting things together in a way that feels palatable and encourages them to continue in this new way of eating. Get your inspiration from everywhere. It could be your NAN, it could be your YouTube. In terms of the vegetables, I've come to the conclusion that it is very difficult to go into be eating that many vegetables in every meal. So I encourage a mix of both cooked and raw vegetables, using frozen vegetables because they are cheap, and not underestimating the taste value of really simple measures like olive oil, lemon, etc. Fat definitely needs education. It's a controversial topic because from as we have heard, I definitely proactively encourage my patients to eat fat. I just do not see patients thriving if they are on a low-fat diet. And again, I use what I know about brain health to educate that they could eat fat while also improving their risk for cardiovascular problems. Advanced interventions, I must say I do this cautiously, and it limits to a few patients who are already aware or come to me at a stage where they are eating reasonably well, and then I would introduce them to try intermittent fasting. I have not yet myself advised or followed up anybody on low carb, but I have definitely signposted many people to the PHC just because I think whatever I advise becomes a part of the care plan, and as yet I don't have the backing from research to make that. But I can tell you patients do that and find it useful. There are many patients who are doing ad hoc elimination, trying to do it themselves because they don't feel like they have the support of their medical practitioners, in which case I will advise them to do it properly, but to do it from a time-limited manner. Do a slow reintroduction and watch for change of symptoms. Learn from patients. I must say that I started out very naive, but I've got more sophisticated and nuanced. And one of the things that I have learned was the value of foraging. So one of my elderly patients taught me about nettles, and then I researched and found that there are about 200 wild varieties of plants that are perfectly edible, that are probably growing all around you, and have at least 400 times nutrients than the aquaponically grown salad leaves that you and I will buy from Sainsbury this week. Yeah? So these are untapped resources that do a multiple of jobs. They get the patients out to the nature. You're connecting with nature. You're picking something that is absolutely free. You get creative with cooking it, and it nourishes your body. And this is definitely a tip from one of my patients. My other tip is not everybody will cook, which is again surprising for me. Why wouldn't you? But people don't. There are some patients who will just not cook. But another of my patients said that not everybody has to cook. Again, food can play multiple roles. So one of my patients started to walk the dogs in her neighborhood in exchange for a hot meal once a week. Yeah, she did it for a few patients. Again, she was a lone patient. I have recommended that to many others, but that just gives me hope that there is no way you as a sole practitioner needs or can have all the answers. So watch out, ask, encourage to see what patients, how they want to do it. Again, not in the communities that I have worked for, but some of my patients have talked about cookery groups in the community run by councils that people have tapped into once they have got interested, tried to change, and then want to develop more skills and have more opportunities to socialize around eating and cooking. So to bring this to an end, just to say that Food is not food in any context, but food is definitely not just food when it comes to mental health. In mental health, food is nurture, food is care, food is about belonging to a family, food is nutrition, food is micronutrients, but food can also become the weapon of attack, of being in a very conflictuous position with your body. It can be a trigger for trauma, but it can also be a source of comfort. And I feel food is a very important medium that can help us bridge the mind-body gap, and that's what I'm trying to do in every consultation with every patient I see.